great minds of today. And the reason why we call it great minds of today is because we know that when we get people together that have great minds on focusing on helping people, those are the people that we want to hear from. And today I have a special guest. You can find Dr. Andreas Gomoll, MD.com, Dr. Andreas Gomoll. It's funny. We were working on the accent. I go right to European every time. And, but again, everyone, you can find that at AndreasGomollMD.com. It's also on the screen. And thank you so much, Dr. Andreas, for being here.
Thanks for having me.
I gotta flip the Andreas.
It sounds very Southern European.
Yeah, I think it's just too thick in my blood. Even if I try to say it normal, I probably start shaking. But on the other end, Doctor, thank you so much for being here. I love what you do, and again, we'd love to hear your story on how you came to the conclusion of starting this company, and then from there we'll go into how you're helping people.
I mean, it sounds like we have a little bit of time, but I don't
yeah, we do.
Be too circuitous. But so I grew up in Munich. So your more like Southern European pronunciation actually kind of works because Munich is sort of this interesting combine of like German being a little OCD and everything is kind of straight and narrow, but it's close enough to Italy to do that with a little bit maybe more relaxation and enjoying life than what you see in Germany. But my dad was a pilot and an engineer, and I always kind of loved tinkering with things. And then back in high school biology class, like the human body is just the most awesome machine there is. If we can't build anything that comes even close. So it took a little bit of a turn from I wanted to build airplanes, which is what my dad did. And then like working with the human body. And initially I thought it would just do bioengineering and build like the cyborg from Star Wars that I grew up with. But then little by little, I actually enjoyed working with people, and it went from engineering more to biology and working with people in med school. But that engineering never fully left, and orthopedic surgery, which is what I do, is kind of the closest to engineering I think you can get within medicine. And then I did medical school in Germany and thought I would just try out the US because this was back in the late 90s. The US was sort of the chosen golden place. If you wanted to have a career in academic medicine, you would need to do something in the US, research, clinical. And I went to Boston, and the plan was for 3 months to stay there. And I ended up doing research at Harvard Medical School and the Brigham for 2 years, and then residency there and fellowship in Chicago. And I liked orthopedics, but what I didn't like so much was orthopedics is very like episodic care. Like you break something, we fix it, and you move on with your life. There wasn't really much of an opportunity to establish a relationship with patients. But one of my mentors, Tom Thornhill, he trained initially as a rheumatologist and became an orthopedic surgeon. That was in the days before medicine had, I don't want to call rheumatoid arthritis a solved problem, but medical therapy is incredible for them. We used to see these patients with crippled hands in their 40s and 50s, and they couldn't walk, and they had every single joint replaced in their body. And you don't see that anymore. Like medicine has almost solved that problem. But that's how he like grew up in medicine, treating that. So he had these lifelong relationships with patients who had seen him for 30 years, and now they're bringing in their kids. And I really like that. And that's how this whole regenerative medicine became more of an interest, because for better or worse, you have a relationship with patients, because as much as I love to solve that problem, we haven't solved it yet. So, you see someone, you transplant something, and I just saw a kid today. 10 years ago, I did something, a femoral osteotomy. So it was really knock-kneed. He had worn out part of his knee, and he was 21. And now he's 31. So we bought him 10 years, and now it starts aching again. So we'll see what the next step is. I need to get a new MRI scan.
Wow. So was it hard when you first started your first business, like from the ground floor? Was it really hard, or how did that flow?
So medicine is business, but it's a little different. What's nice in medicine is you almost have a little bit of a plan where something tells you what's the next step. So like our daughter, for example, just finished college. She's started to work for a bank here in New York, but no one really gave her a roadmap how to get there. So then you apply for college and then you don't know. So
Mhm.
you call friends, you write applications, you talk around, and then at some point somebody hears you and invites you and gives you an internship, and then you get a job. In medicine, there's always a what's next. So you're in college and then, all right, this is how you apply to med school, and you work hard and hopefully then you get in. And then you work hard and then you get into residency, and you work hard and you get a
Mhm.
job. So there's a little bit more of a roadmap. So I would say it helps people who are willing to just throw an incredible amount of work at something, but it's more comforting, I think, than what you have done. And we had a chance to chat a little bit where there's no roadmap. So for entrepreneurs, there's no roadmap. You have to like jump in it and see what happens. And medicine is maybe a touch more predictable. But when you get started, you still have to go out there, make a name for yourself,
Mhm.
convince patients to to give you the most precious that they have. That's their health. Like they put their health and well-being in your hands. And I've done this now. I mean, medical school, I graduated in 96. So it's 30
Oh.
years. But in the beginning, like you just graduate, you have good training, but no real common sense necessarily. And they come to you and they trust you, and you do surgery and you make them better. And then you keep working and you get better.
Mhm. Wow. No, I like that. It's interesting. We live in a society where they want something that fixes them right away, kind of like McDonald's, in and out. And with the body, it's a little bit more intricate. There's more details. What I'd love to kind of talk about is and I'm sure you know this, when you had your first, like, I don't want to say healing, or maybe the first time you were worked with somebody in your own clinic and they were like, wow, I'm feeling better. Like you saw the change, you saw the
Yeah.
split. And we all know it's like, when you made your first dollar. I remember when I was a little kid mowing lawns, I made my first dollar. I was like, dude,
Yeah.
I'm going to be rich. I don't know how, but I see a whole bunch of lawns. I'm just saying, like, there's
Yeah.
something that gets us excited. What was that for you? Maybe there was a healing, or there's something that happened and you're like, I'm so glad that I made this decision. I don't know.
No, I would say that was in residency, and that was sort of part of that shift from the engineering, like putting in widgets, to seeing that there's more than that. And my mentor, who had mentioned, Tom Thornhill, still is an amazing guy, and he's a knee replacement guy. So that's an engineering problem. That's carpentry. And as long as you do it well on day zero and you put it in the right way, they work. But it's also it's a very linear thing. Like you have bone on bone arthritis, you come to see, you check a few boxes in terms of right age, try
Right.
to delay surgery, didn't work, then you get a replacement. One of my other great mentors and friends, Tom Minus, a lot of Toms in my life. Tom Minus, he he was one of the first really to bring cartilage regeneration to the US. I mean, this came
Oh,
out of
wow.
Sweden. There's a guy, Lars Peterson, who like figured out how to culture cartilage cells and then re-implant them into knees and make cartilage grow. And that's now over 40 years ago. And Tom Minus, that has brought it here, and he worked at the same hospital, and he kind of took me under his wings. And that was really eye opening, because all of a sudden it was not just, you put a piece of metal in and that's it. There's no next step really. There are no more other options. It's sort of the final, the, the end in a way, is to do a total knee replacement for a joint. And now here's this guy who you're crooked, we make you straight, you have a pothole in your cartilage, a cartilage defect, and we can fix that. And maybe if you're 60 or 70, I do knee replacement. So it's good surgery if you need it. But here is this whole different world of like regenerating cartilage, preserving your own stuff, if you will, so that you have all these options. And like that 21-year-old who's now 31, he still has his own knee joint. And if somebody comes up with a pill, an injection that regrows your joint in a year, he can benefit from that. But once you have a replacement, you can't. So that really was an eye opener. That was in the late 90s that I met him. So that's where my career veered towards not putting in widgets, but trying to keep your own stuff.
Nice. So stem cells, do you feel like stem cells is, for me, I feel like we haven't even tapped into it. Do you feel like it's kind of more of the future instead of just, it's something that's kind of old and passing? It's been around for a while.
I think, look, it's somehow nature's figured out that we grow from like a single cell organism, like a little amoeba or bacteria, I should say. Amoeba have more, and somehow we become these like big complicated machines that have all sorts of different functions. So we have that plan built into our DNA, and some animals can regrow their limbs, we can't. So I think we haven't even scratched the surface, and I don't think it'll be, at least not in our lifetime, as simple as give someone a pill and they regrow an arm. So there will be more to do, but I think our bodies have the potential to really heal themselves, and we just need to help them out a little bit. So right now that helping out takes the form of these cartilage transplants where I take a few cells out, send them to the lab, they put them in a petri dish, they grow more cartilage cells, and we put them back, or I use donor tissue from organ donors. That's sort of the greatest gift someone can give is their body. But I think the stem cell research is really going to a place where maybe we don't need that. Maybe we can just remind the body that it grew a meniscus, it grew cartilage in the first place. It sort of forgot how to do that, but maybe we can somehow remind it, and then it does its own job.
And it's interesting you say that, because my brain starts to think, if I was a scientist or something like that, I would be thinking right now, okay, well, if there's certain animals or certain species where they're able to regrow those limbs, it'd be like, well, why don't we just mimic that? In a way, it's like, I feel like there's a lot that we're missing. Like you can have a straight line, but there's something cut that we're not, as humans, maybe not tapping into, and it's right in front of us. It just makes me think, I don't know if this is correct. It's something I read, nowadays you don't even know what you rate as even correct anymore, because we don't know. It's just sad the way it is with the internet. We call it Dr. Google, and it's like Dr. Evil. That's my opinion, of course. But it could be good sometimes. But like I've heard of, like, they've had like a half a heart and they've injected a stem cell in there and it regrew that other half. I don't know how true that is, but it's something that I did look at. And but what I'm saying, my point I'm saying is that I feel like we haven't even tapped really into it. With what you do, it doesn't always have to be surgery. Stem cells is one link of the pie. I know that a lot of people are using fillers. I call it fillers. They'll maybe do a stem cell with maybe a PRP, to kind of solidify that so it sticks, if that makes sense. But tell us more about your practice. Like, what are some exciting things that are going on in your practice and the type of people that you're helping right now?
So just to finish your thought on sort of the stem cells and regenerative medicine. So right now we can use that to make you feel better. And that, at the end of the day, I think people care about two things. They care mostly about how they feel. You just want to go on with life, enjoy life, family, be able to work, make a living. But they, in the back of their mind, also have what's going to happen in 5 years and 10 years? And that's where the reconstructive side comes to it, where you don't just want to do palliation, where you may have damage, but you don't feel it, versus the reconstructive, like we actually want to fix the damage. Because life is unfortunately a downhill race and you want to make that a little slower. And PRP, the fillers that you mentioned, stem cells, at least in clinical practice right now, are, I would say, pretty good at making you feel better.
Yeah.
They may slow down things a little, but the science is not fully decided yet on that. They're not regrowing anything yet. And I know there's a lot of advertising and hype out there, but at least what's established, we're not talking about trials. There's exciting stuff coming, but if you see a stem cell clinic, and I'm just talking orthopedic space, not neurology or cancer, but someone can take your own stem cells, spin them down, inject them into your knee, and you'll feel better.
Yeah.
But it's not regrowing anything, unfortunately. But that's where we're heading to. And the regrowing limbs. So there's a lot of research using like salamanders, trying to figure out why can they regrow things that we can't? And the answer is usually cancer, right? So we live a long life. So our body needs to be really paranoid, making sure that our cells divide according to plan and they don't just go haywire and divide crazy, because that's cancer. So finding the right balance of regrowing stuff that doesn't turn bad, that's kind of the future. But what do I treat and see in clinic? I would say it's like young people with old-ish knees. So if somebody comes in and and I'm in my mid-50s, so I don't want to be ageist, but so let's say if someone comes in, they're 70, they're bone on bone, they can hardly walk. By and large, a good treatment for that is still a knee replacement. It's really hard to beat that. But if you have someone who's in their 20s or 30s and they have a knee that looks ugly, if you do a replacement, it's a mechanical thing. It's going to wear out like your shoes or the tires of your car wear out. And then you do it again. And every time you do it again, it's not that you can't do it, but every time you lose a little bone because you fix that metal thing to your bone, it's almost like you have a filling. Like a dentist does a filling, the filling comes loose. You do another one. Each time you lose a little bit tooth. So there's a limit to how often it's done with good success. So the older you are when you started, the better. And my job, I see my job, is to get you from a young age to an age where doing a replacement makes sense. So that
makes a lot of sense.
There are certain non-surgical things, like the easy stuff that everyone tells you, is like live healthy, have good strength, exercise, don't be crazy. Some of the injections you had mentioned, but then also surgery. And sometimes it's just repairing things. Like everyone talks about meniscus, like you tear your meniscus. The answer in the past has been, let's just cut it out. And if you cut it out, then your risk of arthritis goes up. Now, sometimes you have to cut it out because it's just so damaged. So I do that too. Sometimes you come in, you have a big flap and it's in an area that doesn't have blood supply, so you can't fix it. But oftentimes, especially in young patients, you can fix it and you repair it, and the recovery is a little bit of a bear, but then you have your meniscus. So
that makes a lot of sense.
It's trying to take the time and listen to your patients and also figure out what they want. Because not everyone wants the same thing.
What would you say you're seeing a lot, maybe more in your clinic? Like, I mean, what would you say if you could put a number on it? So 80% of my clinic is this, 50% is this, or do you see more of a balance with the things?
What kind of patients?
Yeah, as in certain patients, you're going to have certain patients that are going to come with different issues. They're not all the same.
No, they're not all the same.
That's where I'm saying.
Yeah. I would say, because people now can find me, and it's not necessarily that they look for my name, but they look for the issue they have. And the issue may be, I have an old knee, but I'm young. I have cartilage damage. I have meniscus trouble. And then through Dr. Google, or these days more and more Dr. ChatGPT, they find me. And most of them come in and they're trying to keep their own stuff. So, but the age range is like the youngest is 12 and they have some congenital or developmental cartilage problem. And a lot of patients are, if I would say, with the most common scenarios, you're in your late 20s, early 30s, you had an ACL tear when you're a teenager, you lost some of your meniscus, and now the ACL has failed, you've developed a little bit of arthritis, and you've been told, essentially, take an apple and come back when you're old enough to have a total knee. And they have a young family, they can't really do anything. They can't play pickleball like we discovered both of us too. So that's a pretty common use case scenario, I would say.
Wow, that's amazing. I'm sure you get a lot of people in there with like a pickleball elbow, or because whenever I go on the pickleball court, the average age I see that's all bandaged up. You can always tell the ones that have gone through hell.
Yeah.
On the pickleball court, the tennis court, they have like a bandage on the wrist. They got it on their elbow. They got it on their knee. I mean, they're I'm always telling them, check out stem cells.
Yeah. No, and for those overuse injuries, that's actually a good use, I would say. So there are, because pain also, this may be a little bit of a non sequitur, but pain is not always a sign that something is falling apart, even though it may feel like that. So you just brought up tennis elbow. There's nothing really broken if you have a tennis elbow. It's just, it's inflamed. You didn't stretch enough. You're not using your muscles the right way. So that's something where putting a Band-Aid on, in terms of you do a PRP injection or stem cells, and you go to physical therapy, you don't need surgery for that. You just help your body a little bit and it can heal it. But if you see a 12-year-old and they have a big hole in their knee, if the body could heal it, it would have tried to, especially
Right.
in a 12-year-old. So that's when, and I do plenty of surgery. It's not usually the first step, but oftentimes you need to do that. Depends on what your
100%.
pain is.
Yeah, it's interesting. Sometimes it's little things that we can do ourselves to heal. For instance, when I first started getting pickleball really bad, and I never had a tennis elbow or pickleball elbow, even when I played a lot of tennis. So it hit me hard. I was like, oh, so that's how that feels. And what's weird is it got to the point where from 1 to 10, 10 being high, 1 being low, it would throb in the middle of the night, like at least a 7 or an 8. So I had to use my common sense. Okay, I could do a PRP. I could do this. I could do that. I know what to do. But then I said, wait a minute. If I'm already going to the gym, why don't I just work the muscles around where it's at so I can strengthen it? Had to use the common sense button. And I started doing that. And I was like, wait a minute. It went from pain 7 to like a 3. And I was like, okay. So now I continue doing that. And now, of course, I've done some other things. Not going to go into that, but now I don't have any more pain. So, but it's because the body was, I believe, meant to heal, like you said, but it's utilizing certain modalities. So you mentioned, you do stem cells, but you also do surgery. So it's interesting talking with somebody like yourself, because I do meet a lot of people that just do stem cells, but they're like, no, I don't want to say they're anti-surgery, but they try to stay away from that, and then they'll find somebody like you that can do the surgery. So tell us a little bit, how does this, like when you have someone with surgery, would you normally do like surgery with stem cells, or or is that different with everybody? I'm kind of curious.
I mean, it depends on what they need. So for example, we talked a little bit about meniscus and repairing a meniscus, and meniscus itself doesn't like to heal. Again, meniscus breaks down in most of us. I would say if you see that pickleball crowd, if you just one day grab everyone off the court and do MRI scans on all of them, most of them will have some form of meniscus tear. Not all of them hurt. And if they don't hurt, you ignore them. But if you have a real tear that you want to repair, you, again, need to help the body a little bit. And part of that is just mechanical help. So putting a suture in, like you sew your pants, you sew the meniscus with sutures. But then the extra biological help is putting your own stem cells in. So taking bone marrow stem cells. And it's a comparatively easy thing. Your stem cells are close by. They're in your femur, then your tibia or your hip, but the meniscus doesn't have access to them. So you just take some stem cells at the time of surgery and you just suck them out one place and essentially inject them close to the meniscus and help. And that's a very low-tech, non-fancy. I think everyone should do that anyways. In terms of balancing the surgical thing, nobody, myself included, wants to have surgery. It hurts. It takes you out of your life. It's a little scary. So yeah, if you can avoid it, that's great. But you also need to figure out what your goals are. Do you, like we said before, do you want to feel better? There are more ways to making you feel better, starting with taking an Advil, to how much do you worry about the future? How how deep do you go into this rabbit hole of like engineering, like have a torn ligament or have a pothole or a torn meniscus, and I want that fixed? Because unfortunately, at this point, if you care about fixing it, generally that still means surgery. So we're not quite yet at the level where we just pop a pill, give you an injection, and somehow by miracle it heals. If there's a structural thing. So tennis elbow like yours, that's an inflammatory thing. That we can treat pretty well without surgery. But if something's broken or torn, that still needs surgery.
Right. So what I basically hear you saying is that this isn't one all done all. It's, if you want an extra, you want to get out of pain now, this is it could be good for 10, 15 years, depending on the body. There's no such thing as a pill that's just going to, all of a sudden make you feel great. And if so, everybody would be taking it, including I. We all have an expiration date, but I think that besides the expiration date, people want to feel good during the rest of their life. And that's when they find people like yourself. Hey, you know what? I'm on this bone on bone, so-called bone on bone. As you know, a lot of people will say they're bone on bone, but they're really not. They're still,
Correct.
There's still some life in there. And that's when they can utilize possible stem cells, even,
Yeah.
I mean, I don't know. Again, I'm not a doctor. I'll ask I know enough to get in trouble. But with the stem cells though, the type that you use, are they bioidentical, or are they the cells that are inside the bone? Is that mainly what you utilize, or the fat? I don't know.
Right. So that's when you get the FDA and sort of regulatory, what's allowed, what's not allowed in the room. So the only stem cells that in the US currently are officially absolutely kosher are the ones that come from you. And the only stem cells, at least for what we do in orthopedics, the only two stem cell sources are the ones you mentioned. So bone marrow stem cells, we essentially put a sturdy needle into a bone that has red marrow and you suck them out, or you do the same with fat. Because fat actually contains a lot of stem cells. You need to separate them from the lipids because the lipids are really inflammatory. So you want that. You don't want that. You just want the stem cells. And then you inject that, and you have to do it in the same setting. So you can't put it in a lab and grow it or manipulate it. So it's kind of, the rule of thumb is the stem cells can't leave your bone.
Okay.
Now, a lot of people travel abroad, they get all sorts of stem cells. I would be really careful where you go, because you don't know what you get. But there's a lot coming. So birthing tissue has always been really interesting. So whether that's umbilical cord or placenta or amniotic membrane, we used to actually have access to that in the US prior to, I think it was 2018 when the FDA changed their rules. And it's not that bad stuff happened. It's just at some point the FDA said, well, this is not just some tissue. You are essentially making a product, and that product we want to supervise and make sure it's safe and it works, just like we supervise an aspirin or a blood pressure medication. Right. So then all that stuff had to be taken off the market, and some people still use it, but that's not okay. But now companies had time to do those required trials. They show that, hey, we told you it works, and here's proof that it actually works. So that's going to come back. And I think, especially for the field of regenerative medicine, that's really exciting. The first to come back, hopefully this year or next year, will be amniotic membrane. Because amniotic membrane contains a lot of very complicated molecules that can fight inflammation and can help the body and the joint really heal. So that's going to come soon. And then there's a trial that we're starting probably next year. It's actually a Korean company that's for years has banked umbilical cord blood. Like your baby gets born, you store the blood just in case something happened, God forbid, get leukemia, you can grow more bone marrow. But they've started to use that for orthopedic procedures. Now, in that case, then it's not your own, it's donated, but that's okay. It's immunoprivileged, so you don't have to take crazy medication. And it can actually regenerate cartilage but it's still implanted surgically. So I go in, I clean out the defect, and then we essentially fill the defect with these umbilical cord blood, they call mesenchymal stem cells, and they make cartilage. It's an FDA trial, so you can't go around the corner and get it yet, but hopefully that will come in the next 3 years.
You mean actually regrow?
Yeah, it's really cool. And what's especially cool is that historically cartilage transplants only worked in like young people where the joint looked good and you just happen to have this one pothole. But these stem cells are even applicable, not if you're stone cold bone on bone. That's too late, unfortunately. Right. But if you have some arthritis, so like the moderate one where we didn't really have much because it was too early for a replacement, it was too late for the other cartilage transplants. So that's kind of the new frontier, is to treat that. And that's sort of me, hopefully not you, but maybe at some point you, who don't like to be told just wait another 10 years and then have a knee replacement.
Oh, exactly. It's very interesting. I think it was 2018. The term was, you can no longer use, I think it was stem cells, but you can only use the word mesenchymal. I remember that. Yeah. Do you remember that?
Yeah. And then they said, so then the MSC was mesenchymal stem cell.
Mesenchymal, yeah.
And then somebody said, well, they're not truly mesenchymal. So then, because this is getting into the weeds, but the thought was you put this MSC cell into your body and then that cell somehow figures out what it's needed and it transforms into what's needed, whether that's cartilage or bone or ligament or heart tissue. And then at some point, somebody realized that's actually not what these cells do. They figure out what's needed, but then they send signals, and the cells that are already there, then they do their thing. So then Arne Kaplan was one of the pioneers of stem cells. He then very smartly used the same acronym MSC, but said they're medicinal signaling cells.
See, yeah, I noticed that a lot of people were doing that.
Yeah.
Or cellular.
Yeah, exactly.
You get all Star Wars on us. This is the activation molecule of cellular. I'm playing. But for people that are out there that have given up, there's a lot of people that are in pain right now, and they've given up. They've heard from other doctors and other people, and I'm not bagging on doctors. I'm talking to one, but they're not all equal. Everyone's different. And that's why I always tell people, always get another opinion, because you get an opinion of 10 doctors, you'll probably get 5 that are totally agreeing with each other and the other 5, whatever. But that's in any case with any niche of market in the world. But what would you say to someone that is kind of given up? They're in a lot of pain. They've been told, that they're going to always be in pain unless if they do A, B, C, and D. But my point is there's people out there that have given up. And I believe that people should not give up. It's their health. And I believe if you have a responding person that's willing to say, you know what, I know I can get better, but I just need to find the right person. What could you say to that person out there? Because there are many viewers out there that I know that are in pain and they have given up.
Yeah, so what you had mentioned with the second opinion, I think that makes a lot of sense. Now, sometimes I see patients where I'm the 10th person they're talking to.
Wow.
So you don't want to go too deeply into the rabbit hole. And once you've hit like 3 people who seem qualified and they say the same thing, then maybe that is the answer. Getting a second opinion or a third, I think that does make sense because at the end, we're not rigid. We're not all created equal. And, if somebody starts talking to me about their spine or their ankle, I'm the first person to say, look, that's not my thing. I can point you to the right person, but I don't really want to weigh in.
Right.
What's always annoyed me is when people come and they got an opinion from someone where I know that someone and I know they don't really deal with the problem that I have, and yet they rendered an opinion. So in that case, the opinion should just be the phone number of the person who deals with that. So just make sure that you are somewhere in a network where you talk to a person who's reasonably well connected, like your primary care physician, who can at least pitch you in the right direction. And sometimes it takes a few hops where your primary care physician just knows you have knee pain and he sends you to a knee doctor, and then that knee doctor may be a joint replacement guy who only does joint
Right.
replacements, but you're 25. And then the hope will be that he's enlightened enough to say, well, you don't need me, you don't need a knee replacement, but see this other guy who I sort of know, and he does cartilage transplants or stem cells or whatever
Right.
it is. But then one thing that you had said before really, I think, gets lost sometimes. It's hard work to get better. And you had mentioned your pickleball elbow,
Oh
and
yeah.
you ended up through hard work and sort of trying to be pragmatic about it to get better. And look, I'm I'm a little bit the same. I think we're all the same, that everyone wants an easy button. And I think in healthcare, all too often we want to push that easy button. We want to give our body to someone, they tinker around, fix it, and then they give it back to you, ideally without any effort on your own. And that's rare. Like, I had my appendix taken out. That's probably as close as it gets to that, where I had appendicitis. I called up my friend who was a general surgeon, and he did a laparoscopy, took it out, and a few days later it was good. Awesome. Orthopedics isn't really like that. Like, even if you have a knee replacement, you still need to work really hard to get your motion
Right.
back. And there are many cases where if you work really hard, you may not need surgery or may not need surgery now. But that's working out, figuring out what foods work for you, which is way beyond my pay grade. But losing weight, it's a big discussion these days. Fat is inflammatory. If you have less fat, forget about the weight, but it's also less like bad humors in your body. And then just doing enough of the right thing and not too much of the bad thing. Can't fix everything, but I see so many patients who come in, and if I send them to the right physical therapist or the right, like, myofascial release person, like, oh my God, I'm so much better. And, they don't need me.
I think you hit on a couple keys here. Everything takes work. I mean, if I would have just left my arm the way it was, I would be in a lot more pain. I know that for a fact. You have to put work to it, and our body takes work. You don't wake up looking like Arnold Schwarzenegger. That took work, that took dedication. And when people get to the point and stop thinking, you know what, I need to take a quick, McDonald's bite, meaning I
Yeah.
just need something quick, and they start looking at themselves with some dignity and saying, you know what, I'm worth it. Looking in the mirror, I want to live and I want to be healthy because I have grandchildren or because I want to live longer to be with my family. We need to look at things instead of being selfish. And a lot of us can be selfish and say, well, I don't care anymore. And it's so easy to do that. But when you put work into it, it actually feels a lot more better because now you're realizing, you know what? Because I actually cared, I'm able to do this and to do that. And there's a lot of people that are in their 50s that look like they're in their 70s. It's a trip.
Yeah.
It's interesting if you look back at so I kind of go back old school, like I'm big into like Bonanza and the old movies. And when I look at the people back then that were like 50, they literally look like they were like in their mid 60s, 70s. And it trips
Yeah.
me out. Like these days, it's like people that are in the 50s, you're like, oh, well, you don't even look your age. And I think it has a lot to do with the way people are eating these days, the way they're taking better care of themselves, or not being consumed with certain things. And it's really hard because you as a doctor, somebody gives you a problem. I don't like to use the word problem, but they give you a situation, same thing. They give you a situation and they're like, okay, they come to you, fix it. Not realizing, no, how about you and I, we're going to fix this together. And there's a team and and if you just do A, B, C, D, E, F, G, you're going to see a major difference. But the biggest thing I've noticed with doctors, and I know you've seen this with patients, you can help them, but they're stinking thinking. It's getting in the way.
Yeah.
They're so negative. It doesn't matter. You could have Jesus appear in front of them. They're like, yeah. My
Yeah.
point is that it really starts with, I believe here, not saying, be like a Tony Robbins, positivity. Oh, I just banged my arm. No, I didn't. No, you banged your arm. There's weeds in your garden. what are we going to do about it? But I believe it starts with us first. We have to change that attitude. And I'm sure you get that a lot. And when you do, how do you work with those types of people that are just, we'll just say Archie Bunker. I'm going back now. That Archie Bunker type of attitude. Is
Yeah.
that like an uphill, or is it, how does that work? Because you can help, but they're so negative about everything. I mean, you could give them ice cream and they're still negative while they're licking their popsicle or whatever.
Yeah.
You got me,
That
Mark.
is,
Yeah, now you get me.
no, it's hard. So, especially as a surgeon, if you touch someone with a knife, they become, like it or not, your family a little bit. So you really want to make sure you're careful who you accept into that circle, because just like you say, some people, I have looked at their knees and like,
Mhm.
all right, that's a mechanical thing that I can solve. What I'm having a much harder time with is like what's attached to your knee, like the rest of you. And if you don't get buy-in where people are involved in their care, willing to do the hard things, then it's really hard to make them better. And we've done a lot of research. Medicine overall has done a lot of research tying the ultimate outcome of an intervention, whether it's taking a pill or having a surgery, to psychology. And in cartilage transplants, you would think that if you look at the knee, you say, all right, a certain amount of damage predicts a certain outcome.
Mhm.
And it turns out that if you look at their thinking, their mental status, how they approach things, like, are you resilient? Are you a glass half full or half empty? You can test that. There are all these, if you've gone to a doctor's office, you've done probably these PROs, patient reported outcomes, where you check boxes, do different answers. How you do on that mental psychological test that has nothing to do with your name determines your outcomes more strongly than, is this a big hole or a small hole? And you can change your mental outlook a little bit. So you
Mhm.
can just try and smile. It sounds so silly, but if you smile more, you feel better. Life's not that simple that you can smile away all the hardships we have, but it goes a long way. Sometimes you talk to a therapist, and even if you need chemical help, so you go on an antidepressant, actually your surgical outcomes are better.
Wow.
It's because you feel better. If you feel better, you have more energy, you work harder to get better. And it's this positive reinforcement. I don't mean to simplify like mental health. That's a really complicated thing,
Oh yeah.
but it's exactly the point you have. It's like if someone is very negative, oftentimes they get caught in a situation, and it- not that they actively resisting being helped, it just makes it more difficult. So sometimes it really starts with you, and if you're ready to be helped, then as an engineer, as a carpenter, I can sort of help you.
I like how you say that, as an engineer, as a carpenter, because in a way, that's what you're doing.
That's what I am. Yeah.
It's interesting, and the only reason why I bring that up is because we don't realize that, and we've all been guilty of it, is that what comes out of our mouth, whether it's good or bad, it actually creates and sends signals to our brain paths. And if we're staying consistent in that arena, when I look at a brain, I look at it different. It's like a walnut. When you
Looks
look at
like
the
one.
walnut, right. And what's
Yep.
interesting is, if you see those walnuts, they have what? They have these curvatures, and they have these little tunnels, they look like. And our brain's exactly like a walnut, and we can restructure those tunnels by the way that things that we say. And so it's like, you say one bad thing, it's like, what do they say? You got to say 10 good things to overcome that one bad thing. And, when we speak life to our brain and to others, we're creating new paths. And in that, and it also changes, they've done studies, as in changing even the molecules of certain things. And so I'm thinking, if I come to you and I'm coming full negative, it's not going to help my situation. I'm not going to get better. I'm not going to get better. It's like, okay, wait a minute, easy, tiger. Let's flip that around, and let's look at the positive. It's interesting, because even in my line of work too, I always, whenever I see a negative, and I think it's just kind of in my nature, when I see a negative, I see an opportunity. I see not just an opportunity, but I'm like, let's flip that around. Let's find something good in it. And what's interesting is you can always find at least one good thing. No matter how bad that storm is, you can always find one good thing. Because think about it. If you're in a room right now and I have nothing but pink polka dots everywhere, and I tell you, all right, I want you to tell me how many pink polka dots you find. And then you count after 30 seconds. And then I'm like, all right, how many pieces of blue dots did you see? I'm like, I didn't see any. It's because
you didn't focus on that.
Focus, so I look at it like the human, it really, it's anyways, I know we can go on and on and on, but I just enjoy the conversation. And the reason why I kind of prolong this, now I'm talking to people out there in internet land. When you're choosing a doctor, it's good to see the way a doctor thinks. And one thing I like about just talking with Dr. Andreas here is that he's a very deep thinker. And I can tell he's not one of those one and done docs where he's like, okay, you're one and done. No, let's look at the whole body. Let's look at what we can do. Let's look at how we can fix it, target it, get you back on track. And make sure you guys connect with people that are personal. And if you're looking for Dr. Andreas, you can find Dr. Andreas Gomoll, MD.com. Yep. Go to the mall. I'm playing. Gomoll, MD.com. Please, everyone, you can call the number on the screen, and you can follow him on Instagram, on his social media. He does stay, pretty busy on there and focusing on helping people. And before we leave, Doctor, I just want to say thank you so much for being here. It was a pleasure. And yes, you did stimulate my brain. And I hope others were stimulated out there also. And if you're in pain, you have joint pain, you're having problems with your cartilage, you can go to Andreas Gomoll, MD.com. What's one last thing you'd like to say to the audience, if you wouldn't mind? I'm going to put you on the spot. We didn't talk about this. If there's last words, what would you like to say? Maybe it's about your practice, maybe where to find you, the surrounding places that people can find you, and also because I know that people travel to go see you. So I had to throw that in there.
Yeah. I'm in Manhattan. I mean, getting here is easy. I do see a lot of people who travel. I think, look, I don't walk on water. I try and listen to people. I try and figure out what it is that you need, because some people just need reassurance. Like sometimes I don't oftentimes have to touch them or do anything except say, you know what? Yeah, you have some damage, but you're okay. You can keep doing what you're doing, and it may hurt, but you're not screwing up anything. But sometimes we have to do carpentry, and we'll talk about that.
I love it. And, it's funny. You're like, hey, I don't walk on water, but hey, you did mention you're a carpenter. For those of you that know what that is, I just had to bring that up. But we'll have some fun. Yeah, he was a carpenter. But anyways, on another level, thank you so much, Dr. Andreas. You're a blessing. I love what you do, and pray blessings upon your business, and that you are able to help as many people as I guess that carpenter will let you help out. All right. You have a great one.